Thank you. So our webinar today, we have an opportunity to chat with you all about a study that we did called Costs Associated with Implementing Research and Evidence-Based Practices for Children and Youth. And Kathy, I think you have to advance the slides for me, if you don't mind. Thank you. I wanted to start by just providing a little bit of background information about how we got to this study in the first place. And here, as you may or may not be aware, in 2008, the Washington State Legislature passed House Bill 1088. And that House Bill created an Evidence-Based Practices Institute that's housed in the Division of Public Behavioral Health and Justice Policy at the University of Washington. And the purpose of that institute is to be a resource to help identify and partner with various communities, including families and providers, about evidence-based practices for children's mental health. And so really what we try to do as part of that institute is really support active implementation of effective practice, increase capacity, and promote community voice, and do research on effective practices, as well as supporting legislation and policy. Go to the next slide. Thank you. One of the activities that was done under the EBPS was a gaps analysis for children's mental health, and this I'm not sure how familiar folks are with this study that was done, but one of the really important findings from this was that while there are many areas where there are mental health services where there are people trained, there really is a challenge with capacity for evidence-based practices, especially for depression and anxiety. And so that study, and then also if you can go to the next slide, was commissioned, and there we go. And then they also simultaneously wanted to try to understand more about what the cost of implementing evidence-based practices in Washington State are. And so that's where we get to our current study. And we know we've heard from folks in the field who have said, you know, this is a really expensive endeavor to implement evidence-based practices, and that some of the costs that were perceived at the agency level, there's a real desire for those costs to be considered at the policy level when decisions are being made about mandating evidence-based practices. We really wanted to understand really what are those costs and how do we understand the costs. We also know that there's real need to understand costs from a research perspective as well, that as programs are being developed, really trying to get a better handle on how much different elements of implementation costs would be really important. And then there are also concerns from policymakers who felt like current cost estimates were perhaps too generic, that they were sort of broadly applied national estimates, but that given the specific context of Washington State, wanted to have some increased confidence in the amount of dollars that were being allocated for evidence-based practices. We wanted to understand both total costs, so what would a real investment in evidence-based practices look like if you just started from, you know, everything that's needed, as well as the incremental costs of adding new programs or interventions. And so what that means is looking at, you know, if agency, you know, if multi-care, Consejo, or any, you know, you all would be doing your work anyway, and so what additional costs would be associated with doing the practices. So I saw a note that I'm a little bit difficult to hear. Is that across the board, or is that just with one participant, Kathia?
I think it's just with one. Please let us know if you're having if you're still having difficulty hearing us right now.
Okay, could you go to the next slide?
Okay.
Thank you. So for the purposes of this project, we really wanted to answer 3 questions. The first 2 are the only ones that were really able to answer given the type of research that we had. But we started out with the following 3 questions. So what are the incremental costs and full costs for implementing evidence-based practices? So not just about once you get people trained and how much it costs per client from the moment they're trained, but considering everything that it takes for agencies to get to the point of having somebody trained and then sustaining the intervention over time. The second research question is, trying to understand what shares of the costs go to different implementation stages, meaning how much of costs are associated with planning and early installation of the program compared with sustaining costs over time. And then the third thing we were really interested in, but we didn't quite get enough participants for the study, so this is on our to-do list, but to also try to understand more about what kinds of factors, such as agency size, number of evidence-based practices implemented, how agencies are, whether they're rural or urban, those kinds of things. Can we predict variations in costs? Meaning, are there certain types of agencies that we would want to give, where we would understand that more money would be needed to really support evidence-based practices? And are there ways that agencies can find efficiencies that we could learn from and help other agencies to think through their business models as it relates to evidence-based practices? Next slide. Thank you. So as I mentioned, we have the stages of implementation. We wanted to understand costs across all of the different aspects of when you adopt a new program. So that starts when you start thinking, geez, we have a population of children or families that we have an unmet need for. We want to fill that in with a program and get some training, and so you start with that early exploration of what would be a good fit for our agency, what's available, installation, those kinds of things, trying to understand how you actually get the space allocated, how you get your marketing materials together, all the things that it takes to get the program embedded within the agency. And then initial implementation is, you're finally getting people trained. You have the costs, costs of sending people to training. Even if the training's free, you have the lost revenue for that time that people are in training. And then full implementation is sort of the ongoing costs that are associated with upkeep of the model, and that could include retraining people that are lost to attrition. And then adaptation and sustainability, how do you keep the program going over time? And when you have to make changes to a program, sometimes those have extra costs too. We included in that stage things like doing translation for materials so that they're linguistically matched with clients, any sort of additional training that might meet particular needs. Some agencies, they might do add-on booster trainings or those kinds of things. So we included that in there. The next slide, please. Okay, so Carol.
Yeah, okay. Yes, okay. Can you hear me okay?
You sound great to me. I'm not sure if the other participants can hear you.
Okay. All right, so hi everybody. I'm Carol Levin. I'm a health economist that worked with Sue and Jessica and Kathy on this study. So on the cost study methods, as you can see, our inclusion criteria. Did you go over this already? I'm sorry. It seems like you might have. No, you didn't. Okay. The agencies and any of the agencies that deliver mental health services to children, they had to have implemented one or more evidence-based practice with reasonable fidelity, and at least one of the programs was implemented within the last 5 years. We tried to get variation with regard to geographic locations, agency types, and evidence-based practices, and we did get that. We wanted to have a larger sample than we did, but at least we had that variability. And as you all know, we use this novel web-based survey method, and it'd be really interesting to get your feedback during the discussion on how you guys found that. It's not typical, as you may recall in our early conversations, to use an online survey for collecting data, but it was the most cost-effective way, we felt. We also sent along an Excel companion tool and to try to assist with estimating labor costs for startup activities and recurrent stuff. We piloted the method with 2 agencies outside of Washington, and then beta tested it with 1 agency within Washington. Next slide, please. As you all know, I think the participation was voluntary. We worked closely with the regional support network. We had webinars to go over the study, and we provided technical assistance before the study. We gave an overview of what we were doing and an overview of the kinds of information we would be collecting, and then we were available to provide assistance as needed. And then afterwards we had to come back to a number of facilities and check on numbers that we had, things that maybe we didn't quite understand, or things that didn't look right, or there were data entry issues for validity checks. And we completed that survey between October 2014 and April 2015, so over a year ago. Next slide, please. So here's how it broke down. We invited 30, well actually we sent out the, I think we invited a lot more than 30, if I'm not mistaken. I mean, anybody could have participated. At the end of the day, we got 30 that, how did that 30 come about, Sue? I think we actually sent it out to many more than 30, but maybe I'm not remembering this correctly. But anyway, we invited 30, 19 agreed, 11 did not. Of those 19, 12 were able to complete the survey, and 7 did not. The agencies represented 10 of the 11 regional areas, which is good. So we did have regional and geographic representation, which is nice. Next slide, please. So we were able to get, you know, the facilities we got ended up serving urban, rural, suburban, and frontier locations. They offered a range of services. Many of the facilities were sort of they were both multi-site facilities, but they also weren't just mental health. They provided a range of social services and, you know, beyond just mental health. But there was, within mental health, there was group treatment, medical management, outpatient services, home-based and school-based services, and case management. 75% of those facilities that we surveyed had all of these services available, and as I mentioned, some had even more. And this is important because if they offered things beyond, you know, kind of juvenile youth services and drug rehabilitation and to adults, and you know, this changes the structure of costs for these very, very large organizations that actually do more than just mental health. They serve the community in many ways. So we had some facilities were like that, but then we had very small ones that were just, you know, a very, very small clinic that provided these services. Range of experience of implementing evidence-based practices was for some facilities less than a year, and some had over 11 years with an average of 5 years of implementing evidence-based practice. And then in terms of extensiveness of implementation, they may have been, the evidence-based practice may have been a part of a comprehensive approach toward using that, in which case they were very intentional. For others, it was new and they had never implemented it. You know, one agency had to actually significantly alter their program to support it. And it's quite possible that in many services, EBP is practice, even, you know, and it's not as formalized. So really a large range of service delivery and extensiveness of the implementation. Next slide, please. So, as you all know, the data collection categories are activity, you know, the cartoon is kind of funny. You should do a cost-benefit analysis. The cost of doing a cost-benefit analysis exceeds the benefit. If you were collecting that data and entering it, it is pretty intensive. It's possible that we could have reduced the burden to some degree in collecting information on implementation stages, inputs, labor, supplies, equipment, startup activities if we had come and spent, you know, a couple half days or a day or two at each facility. But you can imagine that that exceeded our budget actually, and so what we chose to do was the web-based service and then provide an incentive to each agency. And we heard back from a few agencies that in fact by their calculation they spent more than $800 in labor filling out these facilities, so they did do a cost-benefit analysis sort of, or a cost study of collecting the costs. Next slide, please. So you can see that we got a nice representation of evidence-based practices for both intensive and intensive outpatient as well as general outpatient. The sites that we visited, we had a total of 27 different of the facilities. They offered 27 evidence-based practices, right? So they could offer more than one. So, for instance, 3 offered wraparound, 7 trauma-focused CBT was the most popular, as you can see, or most frequently provided, and you can see the number of clients for each type of therapy, EBP. Now, this is important, and you know, where you are serving 700 clients or 560 clients or 168 clients compared to where you're serving 6 or 30, we would expect there to be some what we call efficiencies, right? You've put in place training and any kind of infrastructure or materials development, and it's quite possible, you know, the more people you serve, you expect that those costs should be lower. So we'll see how that plays out when we look at the actual data. Next slide. Okay. All right, so what we have here is the, we've looked at an average cost per client for inpatient, intensive outpatient, and the next slide will show general outpatient. We calculated a weighted average cost. What does that mean? Well, as you saw in the previous slide, you know, if you've, you know, if you're serving, you know, if a facility is serving 60 clients with a very expensive intervention and maybe, you know, 120 with a less expensive, we're going to take into consideration the cost and the number of clients that they're serving. So this is what's called a weighted average cost, and you can see that the average cost per client for intensive outpatient is around in the area of $5,700. You can see that that's being driven quite a bit by multisystemic therapy and family integrated therapy, and remember that those ones had FIT served about 46 clients, and MST served about 75 clients. Now wraparound served 168, and you can see how that cost is a little bit lower, and then actually the FFT served 46 clients and FIT served 30. So functional family therapy, even though it didn't serve a lot of clients, is not as very as expensive, and so we'd want to probably look into what are the cost drivers behind that. Then, yeah.
Oh, were you going to say something about, because I think the MST, it's probably worth noting that we had 2 kind of widely different estimates for cost.
Yeah, I mean, yes, this is still the average, so, but sure, I think what we got, one was was closer to 20,000 or something, was it? And then the other, I kind of, let me see.
The other was down more around 9, similar to FIT. And just to point out that number just stands out. It looks really high, and it was a little shocking to me too when we saw it. And one of the agencies that reported on MST, it was they reported on their costs. They had not been a mental health agency before they started MST, and so their costs were really high because they had to go through all of the steps in becoming Medicaid eligible, getting, secure wall, locks, and I think they had to get some cars for their staff to drive to perform the service, and they just didn't have a lot of the infrastructure to support it, and so they have estimated that their costs even have gone way down and are closer to matching. So it just looks a little inflated. I don't want anyone to walk away from this webinar thinking that that was reflective totally.
Yeah, so in fact, if we go into the data, I won't mention the facilities. Interestingly, if you didn't include startup costs, the cost per client for these two was much closer. It was $12,000 per client versus $19,000, and then actually when you take into consideration startup costs and you annualize these, actually, so those are fully with with startup costs in it. You don't annualize the startup costs. So, well, what does that mean? That means that those startup costs, as longer you provide the service, as Sue was saying, those costs are going to get lower and lower the more people you serve. And so in fact, in one facility, the average cost per client dropped down to about $8,900, while the more expensive one stayed up at $17,000, and that's because they'd had to invest so much. And as Sue said, that cost is going down. So yeah, that's those are the costs of that. Let's go on down to the next. This is the general outpatient. You can see that the average cost here is about $830 per client, right? So these are the more, you can see, again, remember that trauma-focused cognitive behavioral therapy, that's about $1,000 per person. There was a lot of variation in that cost, actually, but remember that facilities on the total number of clients seen across 7 sites was about 765 patients. So you can see there's variability in the different evidence-based practices. Some of this might be how, we'll talk about it later, but we did see a lot of variation, actually, and these are averages. So let's go on to the next slide. So I thought it might be useful to look at how do these costs vary by startup and recurrent. And in fact, obviously, for both intensive outpatient and general outpatient, the majority of costs are recurrent costs, those that happen every year. But you can see that general outpatient has, they have $5,800 on average of startup costs. This comprises 9% of their budget, because remember it's lower. Whereas the startup costs, annualized startup costs, in the intensive outpatient is as high as $13,000, and that comprises about 5%. So you can get a sense of really the difference in the costs, total costs for operating these programs on an annual basis. Next slide. Now this slide is, shows that there's really a lot of different ways of thinking about costs. So this is the average, the weighted average of that outpatient cost. I mentioned that's about $800, $830. Now, what we have here is we have the total cost, and that total cost includes startup costs, recurrent costs, and it includes indirect costs and overhead. That means those operating costs that occur and have to be charged to every service. Now, these are not additive, so if you're looking at the slide, don't think that the green bar and the yellow bar equal the orange bar. These are 3 different types of costs. The recurrent costs are only labor, supplies, indirect and overhead, interpreter costs, refresher trainings, report writing, and these are those costs that happen on an annual basis. So if you take out the startup cost, this is what that annual recurrent cost looks like. And then the third one is what we call incremental. What does that mean? That's equal to, that's when if you take that total cost and you subtract the indirect or overhead operating costs. And we did this because we had really a lot of variability in the indirect costs, and I'll talk about that later. It's a very hard cost to capture. Certainly it's hard to capture it consistently across the facilities, and we'll talk about that. So we thought, well, what if we take that out? What does that look like? So, again, there are different ways to look at costs. The The most interesting, I think, is the Incredible Years program. When you look at the incremental cost, the recurrent cost of that program, it's not much, right? It's just that to get it up and running takes a lot of effort. So that's a lot of startup costs are involved in the Incredible Years. All right, next, the other thing to know, so if we can go back quickly, the thing I mentioned earlier is generally the more clients you have, the lower your average cost is. The motivational interviewing is an exception there. Okay, next slide. This is our intensive outpatient. And again, just different ways of, different types of costs that we're looking at. On average, as I mentioned, the costs of this was around $5,600 per client, and there were 9 evidence-based practices, evidence-based programs serving about 400 clients. So the costs range, you know, anywhere from under $2,000 per client to that more expensive MST. All right, next slide. So it's interesting, you know, Sue talked about taking a kind of a novel approach to understanding costs because, you know, as you think about introducing new programs, as you all know, you have to plan for it, you have to install it, you have to implement it. Then there's the operation, there's innovation around how do you adapt it culturally, how do you make sure it's translated, and then you have to sustain the project. So if you look at the implementation, 80%, as you might imagine, is around operation. Now, we think we've underestimated the costs related to planning, installation, and implementation, in part because recall for programs that started 5 years ago or 7 years ago or 8 years ago is not very good, and we'll talk a bit more about that. But you can see that in installation in general, outpatient for evidence-based programs took about 14% of the budget, but in intensive outpatient programs, sustaining those actually activities to supervision, monitoring and evaluation, refresher training, that took about 14%. So they have slight, you know, when you're thinking about a general outpatient program versus an intensive outpatient program, they actually require sort of different, perhaps, emphasis on different things is the take home for this slide. Next slide, please. And then what about how are your input categories? And when I say that, I mean, what about how are costs allocated to labor, supplies, equipment, other services, indirect and overhead, and then sort of mixed training? And so this is very typical. This is what we'd expect, that over 50 to 60 to 70% of the total budget goes to labor, which is expected. And then you can see actually in both, the next largest cost is indirect and overhead, you know, just your general operating expenses for keeping a facility open, and shared sort of your corporate services, you know, that have to be spread to different programs. The next largest is sort of training, takes a lot of, it's a sort of mixed labor and supplies, and training takes up about 7 to 13% of any program. And supplies are around 10%, and that's what you'd expect, and the equipment doesn't take a whole lot in any of these cases. All right, next slide, please. So let's talk about some of the limitations of the work that we did. Well, as you know, the gold standard really, I think, for collecting cost data is to go and sit and to work over a period of time with an agency so that you can help to guide standard data collection across a number of agencies and help with problems of interpretation of the question, help problem solve, like, well, we don't have that data, and then researchers can say, well, do you have this data? Can we back out of this somehow? And so, you know, agencies were self-reporting, sorry, again, regarding reasonable fidelity, so this is a different issue, sorry, in terms of, you know, they were saying, well, yeah, we think we're doing this with fidelity to the actual program, so we had to take people's word on that, so we don't know if they were doing everything exactly as prescribed. We were, as I mentioned, kind of related to this is retrospective data collection, so agencies had to remember and interpret the survey and fill it out, and remembering is not easy. It's not easy to remember what, you know, if you don't have good records, it's very hard to know how much labor went into your startup activities, exactly how many meetings were there when you introduced a new cognitive behavioral therapy, and did you go up to Olympia or to Seattle for planning and training, and these things are difficult to remember. Even though we had a form to help with that, unless somebody's sitting with you and kind of walking through it, it can be challenging. So again, this is also related to the fact that it was web-based. We really don't know how people interpreted the questions necessarily, and if I or a team of researchers were coming to all 12 facilities, you'd have the same interpretation of the question, and pretty much the costs would have, they may be biased in some ways, but they'd be all biased in the same direction. We had a lot of missing data. As I, again, related to all this, some outputs and activities were just very hard for agencies to quantify. And so we think that we've probably underestimated a lot of costs. And again, our study did not consider cost to families or other social services, child welfare, juvenile justice, special education, which all, of course, are related and linked to mental health youth services. Next slide. So I thought it might be. We'll go into this a bit more. We have these challenges estimating costs on all the implementation stages. I've already discussed this a bit. We think that one of the strongest findings from this, we did visit a few agencies that had implemented new methods for tracking resources and linking it to specific services. So we actually think that there's scope for agencies to improve their resource tracking and expenditure analysis. This may mean putting new systems in place, but it would certainly help with planning and even cost control measures, right? If you actually know how much labor is being used across different services or supplies or other resources, you can look for ways to provide services more efficiently, perhaps. Like, let's say you're like, wow, we shouldn't be spending that much labor on this particular service relative to this one. What's going on? Let's see if we can't find out what's happening and how to improve it. We're not sure about the web-based methodology. I'd be really interested to hear folks' opinion on this. And then we do think, though, it's important to capture costs to inform implementation efforts. So we want to continue trying to refine this effort. We think that there's some value to the facilities for seeing these costs, even if they're not perfect. What is the implication for policymakers? Implementing evidence-based practice does cost more incrementally. You saw those incremental costs, both at the beginning as far as startup, but also even recurrent costs. And so when the mandates are being, when the policy is mandating that evidence-based practice be implemented and scaled up, then they need to take into consideration the additional costs and make sure that facilities are, have the means to implement these programs, and that their cost recovery or whatever mechanism they're using for financing is going to cover their costs. And of course, one has to look at the costs alongside the benefits, right? And so it shouldn't, it's a judgment call whether it's worth spending, $1,000 more to kind of prevent depression or prevent prevent mental health illness, because it will overall probably most likely reduce cost to society in the short, medium, and long term. Next slide. So this was this was our experience. The things that if we were to do this again, we'd probably try to put in place stronger questions and forms to capture this. But this is also an area where improved resource and cost tracking by agencies would probably benefit not only researchers like ourselves, but certainly the I think planners in the agencies, as we mentioned in the previous slide. So one, it's difficult to capture startup activities when they occur in the past. So are there ways to track that? Thinking into the future when you introduce a new evidence-based practice, just trying to every quarter say, well, gosh, how much time or how many meetings, how many trainings, what kind of productions material did we have to build out new infrastructure, what exactly did we do, you know, and capture these qualitatively or even quantitatively in sort of your reports. As I mentioned, it's really hard to capture labor for both service delivery and all those folks that support service delivery, volunteers and outreach agents and you know, even your corporate services. You know, these programs couldn't occur without labor from therapists and others. But there really are a few systems in place to capture service delivery hours for sure to different types of therapies and programs. We did see one facility that did that very well, and we wanted to try to learn more from them but haven't been able to share with other facilities. Also, as I mentioned, there are many different types of labor that are needed to provide the service, from therapists to social workers to outreach volunteers, and it's difficult to capture all that labor consistently. Recall is difficult, and there's a lot of variation in the types of labor, the skills involved, and the time spent on providing the same service across facilities, and then certainly different services, different evidence-based programs. And really the big nightmare for me anyway, as the economist working on this, was coming up with a standard definition of overhead and indirect costs. Every facility seemed to have their own way of defining it, calculating it, allocating it, and so we have the less faith in those costs, and that's why for some of our studies we actually pulled those out and just wanted to look at, all right, let's just take out overhead and focus on that, the incremental costs, because the overhead and indirect, all those services are already in place, and so you don't have to build them up to support introducing a new practice. So one could argue that you just can omit them, and as we saw, they are about 14 to 18% of total costs, so one can just recognize that those costs aren't being captured. So I think, let's see, last slide. Oh, no, I believe that is my last slide.